I'm Dr. Shaukat Iftikhar, and today we are going to talk about the prevention of colon cancer. I thought we will talk mainly about the prevention and early detection of the colon cancer, because if we can do that, then we probably don't even have to talk about the symptoms or treatment of the cancer, and that's the goal, to be able to prevent it before it happens or detect it early enough so where we do not really have to talk about the different treatment modalities that are available. This is that colon cancer is the third most common cancer, 148,000 cases. The second most common cancer when it comes to total cancer death in this country. About 50,000 people would die every year from colon cancer. And currently more than 1 million Americans are actually living with colon cancer at different stages. So this slide is not meant to scare anybody, it's just to tell us that it's a very common cancer and needs to be taken seriously. And the good thing about the colon cancer that it is one of the very few cancers that are actually preventable. You know, unfortunately with many cancers we don't know about them until you have them. And once you have the cancer, it's pretty hard to treat them. But colon cancer is very different. It can be detected even before it starts, and it can actually, there are things that can be done to prevent colon cancer from happening in the first place. When you look at the risk factors, age is obviously a big risk factor. 90% of the cases happen in people who are 50 years old and older. And African Americans are at higher risk than Hispanics, but since it's such a common cancer, really it doesn't matter what race you belong to. It affects pretty much every race and people of every ethnicity. There are a couple of other conditions where you may be less than 50 years of age and still be at risk for colon cancer. If you have history of Crohn's disease or ulcerative colitis, no matter what age you are, the risk of cancer is there even before you hit 50. And similarly, if you have family history of colon cancer or polyps, especially if you have multiple family members with colon cancer or polyps, and especially if they develop cancer or polyps at an early age. There is another slide which shows what I just said initially, that colon cancer does not happen overnight, and which is good. The very last slide is of a cancer. You can see that a circumferential tumor in the colon, and the slide in the middle is a polyp, and then the slide on the left is normal colon. So it doesn't happen overnight. It takes about 10 years from a normal colon to become cancerous, like the last slide. And it goes through the stages, and developing a polyp is the middle stage. So basically you go from a normal colon to a polyp that's small in the beginning, then it gets bigger and bigger, and this is a pretty big polyp. And then still at this stage where the polyp is pretty big and may have cancer in it, you can see that there is a whitish or light pink stalk between the actual polyp and the wall of the colon. And even if there is cancer in that polyp, this stalk will always be free of cancer. And what it means that if someone can go in with a colonoscope and resect the polyp where the stalk is, then you're going to get rid of the polyp even if there is cancer. So you're going to get rid of everything, even at that stage, which I can tell you it's at least 5 years from the stage number 1 of the normal colon cancer. But if you do not get a colonoscopy and this polyp stays there for another several years, then you're dealing with a colon cancer. And that cancer obviously would require surgery, maybe chemotherapy, and we'll look into that may not even be curable at that stage. So therefore a colonoscopy at age 50 or whatever age it is appropriate for you is very important, because it's very likely that you will find not a cancer, you will probably find a polyp at at different stages of development, and then you should be able to easily resect it and can protect that person from ever developing the colon cancer, or the last slide on this one. If you find a cancer that is confined to the colon, then you will be able to take that cancer out by surgery, and your chances of living 5 years is almost 90%. So if we detect it early, even if it is a cancer, not a polyp, you already have a cancer, even if it is found early, you still have a 90% of chances of living for 5 years and maybe many more years. If that cancer has spread to the regional structures outside the colon, lymph nodes, uterus, bladder, your chances of living 5 years drop down significantly to only about 65%. And if we wait too long and you already have the cancer in the liver, let's say for example the chances of us living for 5 years is less than 10%, meaning at that stage, if I find a cancer of that stage, 90% of the patients, or 90 out of 100 patients, will die within 5 years. But if I have found that cancer a couple of years earlier by a colonoscopy and have found it when it was confined to the colon, there was only 10% or 10 out of 100 patients would die before they, within 5 years. The other 90% will live for 5 years or maybe 20, 30, or 40 years. So this is another very important slide to show us that we have to do everything we can to find a polyp before it turns into cancer, and if that is not possible, to find a cancer at a very early stage, because it does impact significantly how long we're going to live and how well we are going to live if it is found early versus if it is found late. So therefore, I will talk about some of the methods of screening colonoscopy. Now, so these are some of the ways that you can try to find a colon polyp or a cancer. The first one is the fecal occult blood testing, basically checking a stool sample for the presence of blood. Flexible sigmoidoscopy is a short colonoscopy. So it's very similar to a colonoscopy, but instead of going all the way to the end of the colon, you cover about 1/3 of the colon. And if you do not find any polyp or cancer in 1/3 of the colon, then you assume that there is no cancer elsewhere. Makes a lot of sense. Well, that used to be one of the methods to screen, for colon cancer. People rarely use it, because I basically tell my patients that if you hear a noise in the house in the middle of the night, you're not just going to check one room and say there is nobody in the house. You're going to check every single room to make sure, and you're probably going to check a couple of times before you go back to bed. So, and then some people suggested in the past that we combine the sigmoidoscopy with the fecal occult blood testing, and we'll talk about that. Colonoscopy, everybody's familiar with it. Double contrast barium enema used to be pretty popular. That's an X-ray where a tube is placed into the rectum of the patient, then they inject a lot of barium, distend the colon, take pictures. Let me talk about some of them here, and then we'll go into detail of some of them. And there are a couple of new ones. One is the stool DNA testing, and one very popular one is the CT colonography, or where people call it virtual colonoscopy. So we'll talk about those as well. So sigmoidoscopy we talked about. The barium enema has also fallen out of fashion. Number one, because it's a very crude test. You miss the small polyps, you miss cancers. It's very uncomfortable to have a barium enema because there is no sedation, and there is quite a bit of insufflation or distension of the colon, which can cause discomfort. So barium enema has pretty much nobody uses it. Sigmoidoscopy, nobody uses it alone, but some of the other tests are still being used, and we'll talk about them. This is a slide that shows you how good checking the stool for blood is. Now, if you look at the first column where it says 23.9% and 43.9%, let's look at the bottom where it says 4.9% and 9.5%. If you have a stool test in your doctor's office where they take a little sample of a stool, put it on a card, put some drops, and say, oh, you have no blood, that test will detect only 5% of polyps. It means there's a 95% chance that you do have a polyp, but it didn't show up on the test. There is another way to check the blood in the stool, which is a little bit better, but not a whole lot better, is if you take 3 cards home with you. The doctor will give you 3 cards, and ideally you wait for 3 days and use 1 card a day. Take a little bit of a stool, put it on the card, seal it, bring it to the doctor's office. Even with all this, your chances of missing a colon cancer is about 50% or more. So even if you do 3 samples, 3 days, exactly as your doctor has recommended, you're going to miss more than half of the cancer, and you're going to miss about 2/3 of the polyps. Now, there is a stool DNA test, which is new, very popular. Companies are promoting it. And it's a much better test than checking a stool for blood. What this test does is basically look for the cancer cell itself. So if you have colon cancer, some of the cells will shed into the stool, and the stool sample will actually contain colon cancer cells. And those colon cancer cells have an abnormal DNA that can easily be detected. So if you take a sample of the stool and you look for the DNA, for an abnormal DNA, you're likely going to find it in the stool sample. Polyps typically do not shed cells, and if you have a polyp, you're not going to find it until it progresses to either a late polyp stage or early cancer stage. So basically, you have to wait until you have a very large polyp or a cancer before it starts to show up in this test. Obviously, there are some good things about it. You don't have to be put to sleep. You don't have to, spend thousands of dollars. Well, insurance companies, and this is one very new good thing that has happened in the last few years, that all insurance companies have been mandated by the government to pay for the screening colonoscopy. So otherwise, cost would be an option. So this is a better test than the other test, but then the problems with this is that it misses some cancers, obviously. You are not going to find every cancer. Its sensitivity for polyps is very low, so you can have a polyp and still have a negative test, and the test will not turn positive until you have a cancer, which is not the ideal situation. And then it's not covered by most insurance companies, and if you have a negative test, nobody knows exactly how frequently this test should be done. So there are no recommendations how frequently you should have this test done. And if the test is positive, then what you need is a colonoscopy. So then you end up having two procedures, having to pay twice. So those are some of the limitations of this test, that if it is negative, you don't know what to do with it. And if it is positive, you need a colonoscopy, which would have detected polyps and cancers anyway, and you really didn't have to go through this. So stool DNA test is available, but it's not very popular because of those reasons. It says not clear how to manage positive stool DNA test if colonoscopy is negative. And this is another dilemma, that I have seen patients who have positive stool tests, then they came for colonoscopy, and colonoscopy was negative. Now what are you going to tell your patients? One test is positive, one is negative. So there are a lot of false positive and false negative with these tests, which sometimes complicates the situation. This is virtual colonoscopy. Again, no sedation required, and it is considered to be less painful, or some people will say painless procedure. It's a very good test. You can see on the first slide, let me walk over mine. You can see here that there is little abnormality of the lining of the mucosa, and this is a CT picture. And if you do a colonoscopy on this patient, you will see that this patient has a polyp in the exact same location. So if you have a polyp like this, it will show up on the CT colonography or virtual colonoscopy, just like this. So this is a very good test to detect polyps and cancer, although it also has certain limitations, and we'll talk about those. The limitations are obviously, number one, it requires a full ball prep, just like a colonoscopy. So some people think that they would not have to drink the nasty stuff that you have to before colonoscopy. That's not true. We like you, we love you, we still like you to drink, that stuff. The colonoscopy, if it is positive, if a polyp is found, then obviously you have to have a colonoscopy. So most patients will end up having colonoscopies, or many patients will end up having colonoscopy, and then they will have to pay twice. And there are a couple limitations that I would like to talk about. Obviously, it's not available, and it's not available in many places because there aren't that many radiologists who are trained to read it. So maybe in the future we'll have more hospitals who have this technology and more radiologists competent, and that may be a good option for some patients at least, if not for everybody. And it is still not covered by most insurance companies as a test for screening colonoscopy. Obviously, there is risk of radiation, which is not there with colonoscopy. And the management of small polyps is a question, and I think we have some slides about the polyps. The another caveat is this. Now, this virtual colonoscopy is very good in picking up polyps or cancer that are protruding into the lumen. So the first picture, if you have a polyp like that, it will almost always be picked up by virtual colonoscopy, no problem with that. But then if you are talking about the second picture, and especially the third and fourth pictures, and there has been a lot of interest recently about these flat polyps. You know, we always thought polyp as a growth that can easily be seen, but now we are recognizing that many polyps are very flat, and I have some pictures to show you. And these flat polyps will not be picked up by virtual colonoscopy, or will be likely missed by virtual colonoscopy. And now we are learning more about other kind of lesion which we call depressed lesion, where in contrast to you having a growth, you basically have an ulcer. And that ulcer can be a cancer and will likely be missed on virtual colonoscopy as well. Another problem with virtual colonoscopy, you go get the test, and when the doctor looks at it, you're gone already. So if the doctor say, you know, this area looks suspicious, I would like to look at it again, there is no way that they can look at it again. You are already at home eating your dinner. But with colonoscopy, if we see a suspicious area, we can stay there for as long as we want, we can take a biopsy, we can go move back and forth, and we can look at it several times until we are satisfied that this is not something to be concerned about. This is a normal colon, looks healthy, perfectly fine, no problems there. And here it looks normal too, but if you look very carefully, there is a polyp there. You may want to look here, and you see it's a very big polyp, fairly big, but we call it a flat polyp. Even on colonoscopy, it's not visible very much. And these are the kind of polyps that will be missed on barium enema for sure, and even CT virtual colonoscopy. And this is something that we are learning more and more about, and that's where the colonoscopy is better than any other test to detect these polyps. And it is an early polyp, but not so early. You can see it's flat, but it's spreading like a carpet, and it's probably being there for several years. Another advantage of colonoscopy, this is a colonoscope looking at a polyp. You can see it, you can snare it. This is a snare which is around the polyp, and all we are going to do is to close the snare as we apply some heat, and this is going to resect the polyp. So this is pretty much the only screening test, colonoscopy, where you are not only will be able to see the polyps, but you will actually be able to remove them at the same time. So this is the main benefit of colonoscopy, that you can not only find polyps at their early stages or later stages of cancers, you can actually take a biopsy to make sure that these are precancerous polyp or not precancerous polyp. And most of the polyps can actually be removed, which means you do not have to come back, you do not have to have surgery, you're done basically. Now, a few things about how to prevent colon cancer. Fiber is important. The more fiber we eat, the better. There's a lot of talk about aspirin. Talk to your physician, and if they have no trouble with you taking aspirin, usually the most of the data that suggests some benefit is with a 325 milligram of aspirin, not the baby aspirin, and you have to take it consistently on a long-term basis. Exercise. A lot of diseases, it boosts your immune system. Good immune system is effective against cancer cells, not only against infection. We know that obesity is, now we are learning, is a leading cause of most cancers. So this is a growing concern, and this is a growing problem, you know, for our nation, that more and more people are falling into this category of being obese, which certainly carries a much higher risk of multiple diseases, including colon cancer as well. Thank you so much.
I have been coming to these programs for several years. I am a cancer survivor myself, so I'm always interested in coming to the programs about any kind of cancer. I enjoy hearing the doctors and the nurses and the nutritionists and everyone who comes to speak. They're very informative. I thought today's program was one of the better ones.
I'm Sean Perkins. I'm a GI and thoracic nurse navigator here at the hospital, and the cancer awareness programs, from what I've seen, have been great to educate our public that's already very well educated, but also to reinforce that and let them have a very one-on-one discussion with physicians about current issues and screening, as well as prevention and treatment of different cancer diagnoses.